Hi there. My name is Elliot Bent. I plan to be presenting slides for UVM Medical Center. Could someone turn on the screen sharing feature for me, please?
Tara, this is Susan Barrett. Hi. Can you turn on the screen sharing feature? Did you hear that? I think you just got on.
Yeah, it's for Elliot Bent.
Okay. Thank you,
Thank you.
Elliot. We'll take care of that for you.
Is Dr. Merman here?
Graham.
Hey, Dave. Hey, good to see you. And member Teach Out? Great. Second. And do we have a court reporter this morning? Is it Miss Mulligan? Kristen, do you know who the court reporter is this morning?
Jessica Baldischweiler. I hope I said that right.
Yes, I'm here. I'm present.
Hey, good morning, Jessica. How are you?
Very well. How are you?
Well, are you all set?
I am all set.
Okay. Then I will call the Green Mountain Care Board's hearing of August 5th, 2026 to order. We have 3 hospital budget presentations this morning. From 9 to approximately 11:30, we have the UVM Medical Center, and 12:15 to 2:30, we have CVMC, and 2:45 till approximately 5 p.m., we have the Porter Hospital budget presentation. Dr. Leffler, are you and your team here?
Chair Foster, we're here.
Great. Good morning. Good to see you again.
Good morning.
Ms. Corlman, would you mind swearing in the witnesses?
Yes, absolutely, I can. Just like we did the other day, if everyone can please all read the oath, and then whenever you take the oath, if everyone could please go individually and say your name beforehand, that would be very helpful. All right, is everyone ready to go?
Yes.
Okay. So do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalty of perjury?
Steve Leffler, I do.
You. Judy Peakley, I do.
Mark Stanislaus, I do.
Rick Vincent, I do.
Ramsey Harrington, I do.
Jennifer Gagnon, I do.
Bradley Crumpf, I do.
Great. Thank you all. And thank you all for being here again. I will turn it to Dr. Leffler for you and your team for your presentation.
Thank you. So first off, I'll just say it's good to see everyone again. And today I am wearing my UVM Medical Center president hat. Really much of what we talked about on Monday was focused on the broader challenges and opportunities facing UVM Health. But today we really want to focus on UVM Medical Center and the themes of what we're trying to focus on here as we provide care every day at the state's academic medical center. Next slide, please, Jen. So as an academic tertiary care center, UVM Medical Center has the privilege of often being the only hospital in Vermont to provide quite a few services to our patients and to our community. One example is our Children's Hospital and our NICU. I do want to comment that our Children's Hospital received a national 5-year, $25 million grant from the Golisano Foundation. Continuous amazing work in all areas of clinical care, but particularly in terms of innovation around quality in children's care for our region. One thing that's unique about UVM as an academic medical center is that while most academic medical centers have a community hospital in their local catchment area, we actually are the community hospital as well, and we're the sole community hospital. And this comes with a different type of service to the patients that are local, to our communities, than what we see at most other academic medical centers. It means that we must continually adapt and collaborate to meet the challenges in Chittenden County, particularly around emergency department care, primary care, mental health, substance abuse, and long-term care. Next slide, please. There are many advantages that I believe that all of us as Vermonters realize by having an academic medical center based here. And while we've always been upfront that CMS does not cover the full cost of our GME program, we do believe strongly that Vermonters are healthier and have greater access to specialty care due to our GME programs. GME improves access through many mechanisms, but first, most importantly, probably by bringing nationally and internationally recognized experts who choose to come to Vermont because they're attracted to our teaching mission. Also, by training the next generation of physicians, nurses, and other health professionals, many of them choose to stay in Vermont after their education across the entire state. We would not be able to have the specialties and subspecialties available in Vermont without being an academic medical center. And there was recently an amazing story about a teenager who made a full recovery after receiving life-saving brain surgery from the only pediatric neurosurgeon in the state. And that's an amazing story, but actually there are stories like that every single day that happen at UVM Medical Center because of our academic providers that are here providing high quality care to all of us. The quality of care that we're able to deliver is improved through research, innovation, clinical trials, and the adoption of leading clinical practice by our academic providers. And I want to be clear that the knowledge and expertise doesn't only reside at UVM Medical Center. It extends across the state through provider education, consultations, and partnerships with all of our community hospitals. We often hear, is it affordable to have a GME program or an academic system? But you have to remember that it's not just the cost of training programs alone, but what the cost of care would actually be without our 377 residents and fellows, or the many others who are attracted to our mission of training the next generation of medical providers at UVM Medical Center. In short, I strongly believe that our partnership with UVM is one that produces enormous benefits to Vermont. Even as we agree with Nancy Kane and the license team on their comments on Monday about the need to examine the way medical education is funded across the United States, I strongly believe there's huge net benefit to Vermonters having an AMC here in Vermont. Next slide, please. So quality is really a central focus of everything that we're doing. And I want everyone to hear that as we transform our operations, maintaining and improving quality is job one. It's non-negotiable. I'm happy to tell you that today, UVM holds a 4-star CMS rating reflecting improved performance across many measures and the incredible dedication of our teams. And while we are proud of that achievement, UVM Health's goal for all hospitals, including UVM Medical Center, is 5-star performance. There's really difficult work in front of us to regain our 5 stars, but we're committed to that work. It will take time, but we are focused. And if you look at the CMS report right now, our biggest opportunities for improvement are in the safety of care and timely and effective care. And what I really want you to know, there's a wide variety of measures that sit under those. And we're extremely focused on those right now in doing the work to bring those scores up to be a 5-star institution at UVM Medical Center. Our current data shows improvement in some of those measures and challenges in others, but that's the nature of quality improvement. You have to keep gathering data, reviewing the data, and making continuous change and improvement to succeed what you're trying to accomplish. So we are very focused on that. We expect the impact of these improvement efforts today to be reflected in our future public reporting cycles, and there'll always be bumps in the road, but we are committed to being on a journey to be 5 stars at all the hospitals you're going to hear from today, but specifically we're talking about UVM Medical Center right now. Next slide, please. I want to also talk about affordability. I want you to know that as I talk across UVM Medical Center and UVM Health, I tell everyone, our leaders and staff repeatedly, that affordability is our responsibility. And we are taking that responsibility very seriously. This year, UVM Medical Center, working with Blue Cross Blue Shield of Vermont, reduced our reimbursement rates by an average of 12.3%, starting January 1st, 2026. We recognize that for outpatient services, we have been historically higher cost. And so in 2026, Imaging came down 25% for MRIs, and CT scans. Labs came down an average of 13%. Other outpatient services an average of 20% decrease. I wanted to just highlight a few common CPT codes to show you the impact that has for people seeking care here. Routine global obstetric care for vaginal delivery came down 10.29% for our charges to Blue Cross. An established primary care visit came down 54.92%. Lab studies like a comprehensive medical panel came down 32.55% in charges to Blue Cross and our commercial insurers. A surgical knee arthroscopy down 10.56%. MRI of the brain without contrast down 25%. These changes have a real and immediate impact for Vermonters with commercial insurance, as co-insurance payments came down commensurately with that. And while there's clearly more work to do, these are tangible examples of the progress that has been made and our commitment to taking meaningful action. These changes, as well as the reductions made by Act 55, are important to affordability for all Vermonters, and they have led to an expected decrease in revenue because of it. The FY27 budget, which Judy's about to take you through, has a negative $43 million loss, which represents our best attempt to balance required expense reductions for affordability and our commitments to maintaining access to Vermonters and meeting our quality goals. I appreciate the great questions on Monday about whether the medical group's initiatives to increase efficiency will result in an increased NPR, increase compared to what we've budgeted. And I want you to know we spent significant time considering that. And Judy will spend time talking about that in detail. But the honest short answer is, it's too early to say whether we'll see more commercial revenue as a result of these efforts. How much more, and when and within the system it'll show up. Will it show up at UVM Medical Center, Porter, CVMC, or other hospitals across the state? We're still in the early stages of this turnaround. And right now, today, as I sit here, our commercial revenue is still significantly below budget. We're forecasting tens of millions of dollars of losses in 27 on top of our losses for 26. I believe as we present this budget, it'd be premature to make decisions based on that without the clear data that we'll have over the next couple of months to understand better what the changes will bring. But our commitment to the Green Mountain Care Board is we'll report on our financial situation on a monthly basis. If partway through 27, the revenue picture looks better than we are budgeting, we can work through that together based on real data and take action, as we have in recent years at both UVM Medical Center and CVMC. So with that, I'm going to turn it over to Judy. Thank you very much.
Thank you, Dr. Leffler, and thank you to the Green Mountain Care Board members and staff for the opportunity to be here to present our FY27 budget. Before we walk through the components of our budget for fiscal year 27, I want to take a moment to provide an update on where we are for fiscal year 26. We recently submitted our Q3 report on our financials to the Green Mountain Board finance team, so there are additional details available in that submission. Overall, we are projecting a significant loss for FY26 that is causing more than a $54 million deviation from our FY26 budget. Some of the drivers of this projected variance are lower commercial revenue based upon the agreement that Dr. Leffler spoke about with Blue Cross Blue Shield of Vermont, as well as larger than anticipated negative impact from Act 55. Looking at the other revenue section, it is exceeding budget, specifically in our retail and 340B contract pharmacy arrangements where volume has been increasing, and I'll have more detail on our retail pharmacy later in our presentation. Linked to this increase in volume is also an increase in retail drug cost of more than $75 million. But a reminder that additional cost is not impacting affordability because it is covered by the additional revenue generated from our retail pharmacy. Other expenses are increasing and they're listed on the screen as well. And there are more details around that provided in our Q3 update. You'll see many of these things again as we talk about FY27 budget. So now let's take a look at the benchmarks for commercial NPR. What you're going to see first is a slide that represents the adaptive system for what it considers commercial revenue resources. So what you have on your left-hand side is the current adaptive system and everything that goes into commercial revenue. Earlier this year, we met and had conversations with Green Mountain Care Board finance staff. They've seen this grid and they've actually given us some input on what you see today. As we assess the effectiveness of our actions on ratepayers, those businesses and individuals that are impacted by commercial premiums, we're focusing on what I'll term true commercial. Since we already provide self-pay discounts, financial assistance, as well as pharmacy program support, self-pay is not monitored or managed in the same way as actual commercial. In addition, workers' comp and public agency payments, like from the VA, as well as motor vehicle claims, are currently captured in commercial revenue, and they also are not negotiated as those rates are set. We're unable to impact those. So where can we improve? As demonstrated during our FY26 negotiations with Blue Cross Blue Shield of Vermont, we're focusing our efforts and measuring our success based upon major commercial or true commercial that you see in the dark blue on the right side of the slide. We ask that the Green Mountain Care Board monitor and measure our success and that of all Vermont hospitals in the same way and exclude self-pay, workers' comp, and the other category from true commercial guidance in the budget orders. Next, we'll review the commercial rate benchmarks. And you will see that UVMMC is requesting no change from our current reimbursement rate, which on the surface does not meet the -1% guidance. However, we are already exceeding the underlying affordability goal of this benchmark with a functional 4.7% reduction based upon the FY26 actual impact of the reductions at UVMMC. On the next slide, I'll show you how the actions taken by the Green Mountain Care Board, the Vermont Legislature, and UVMMC in conjunction with Blue Cross Blue Shield of Vermont is achieving the required rate and NPR impact. The top portion of this slide walks through the FY27 budget guidance as well as the FY26 budget order that results in a required commercial revenue reduction of $32.4 million. Below that are the actual FY26 impacts that exceeded the FY26 budget and continue to impact our FY27 budget. You'll see the impact of the Act 55 that exceeded our budgeted expectations. That's carrying into FY27. In addition to Act 55, we also have the additional impact carrying forward of the Blue Cross Blue Shield rate reductions that were negotiated in FY26. Lastly, we reported some known coding changes that occurred after the budget was built for FY26, and those will continue to impact FY27. When you factor in those three known items, they amount to nearly $34 million in commercial NPR reduction, which, as you see, compared to the commercial reduction required of 32.4, is exceeding that budget guidance. The next slide, you're going to see the impact of that rate, as well as the calculation that we used for transparency to arrive at those numbers. As we move past the commercial NPR, we want to take a look at the other revenues. And other revenues specifically around pharmacy revenue. Our retail pharmacy that you see on the screen here has two components: retail pharmacy and our contract 340B pharmacy. I'm not a pharmacy expert, but I will attempt to give the distinction between the two. Retail pharmacy that you see includes prescriptions dispensed from our own pharmacies. And the drivers for the increase there are primarily volume and revenue related with what we call specialty pharmacy. The largest number of drugs coming onto the market are in this category of specialty drugs for rare disease management. Think when you turn on your TV and you're seeing advertisements for new drugs like Skyrizi. that treat Crohn's disease and other things. That's what we're classifying as a specialty drug, and that is where the market has been launching the most new drugs. A contract 340B pharmacy includes prescriptions filled at other pharmacies, think CVS, Kenny's, Walgreens, for which we have a contract pharmacy arrangement and have an alternative replenishment agreement to supply those pharmacies with the drugs to complete prescriptions. I'm going to see some variance between our budget, our projection, and our FY27. Primarily in retail pharmacy, it's the growth of the market for specialty drugs that I mentioned previously. In our contract 340B, you see an increase in 26 and a slight reduction in 27, and that's really based upon the timing of the implemented law that protected our contract pharmacies across the state. Next, we're going to move on to expenses and how they're comparing with the benchmarks in the FY27 guidance. This slide really is just our growth at a glance and how we're seeing it and where we're bucketing it in terms of what is controllable and what are areas that we really have to look at the drivers of it and determine what we can and cannot control. So moving to the next slide, we'll walk through how we move from 8.4 to 5.4. This slide shows the approved expenses excluded from the 2.4% threshold listed first. We've also included retail pharmacy expenses for exemption consideration. As outlined in our joint memo with Rutland Regional Medical Center and supported by liaison team's testimony and memo, we respectfully request that the retail pharmacy expenses be excluded from the expense growth cap. If that change is approved, our true operating expense growth would be 5.4%. On the next slide, you're going to see that while we just reviewed retail pharmacy, this is pharmacy impacting the care we deliver. So we are also impacted by higher drug costs. Our pharmaceuticals overall, including chemotherapy drugs, is going up $37.9 million. That is 23.6% overall. This is certainly significant budget to budget, and it's going to look larger for UVMMC based upon the type of care that we deliver. Without these increases, many of which will not be fully recovered through revenue, our expense growth will be around 3.9%, which is still above the 2.4%, but it is much closer. We're seeing a similar pattern in other areas of expense growth, such as on ortho implants or neuro implants, guide wires, and things that we use in our cath and EP labs. So what are we doing to try to negate these rising costs? We're focused on renegotiating prices on med surg supplies and other contracts. And we've already included over $11 million in anticipated cost savings for those efforts that will be undertaken. Those are already in our FY27 budget. Other areas that we're focusing on are premium labor spend, and you're going to see that in the next two slides covering travelers and premium pay. Each month, I report traveler and premium pay cost along with productivity measures, and I share this information with the VPs and the directors, and our financial analysts work close with each department to try to identify where improvements are needed. We use this data to guide decisions about filling positions. We use the same discipline across other expense categories as well. Our FY26 goal that was in our FY26 budget to be down to 144 travelers has proven very hard to achieve. And you can see we're still running in the 170s. We're aggressively targeting a large reduction for the remainder of FY26, and that traveler reduction work is already underway. We are budgeting for continued improvement and cost savings in FY27, with a goal of getting down to 114 travelers. While we would like to get to zero, it's simply not achievable in the current healthcare environment with national shortages in certain areas such as respiratory therapy and hard to fill areas in our sterile processing, our complex radiology modalities, and in RORs, where our travel reliance is the highest. Where we've made strong progress is reducing many nursing travelers, while recognizing that recruiting and training new staff does carry its own added costs and temporary lower productivity. The next slide shows the other area of premium labor spend that we were focused on now and in FY27. Premium pay is the extra pay we provide to our own staff. That includes urgent, overtime, called in, and some pay carries double time pay rates, which can be more expensive than a traveler. FY26, we're projecting to spend $27 million in this area against an $18.9 million budget. And that's actually projection has come down compared to our run rate because of the efforts we are making. But why? Why is this happening? A big part is having to train new staff. While that person is being trained by an existing staff member, the trainee is not productive and the trainer is less productive. So we have to have others pick up uncovered tasks. And also, to be honest, we've not consistently flexed our staff to the lower volumes. In healthcare, you always fear what might come in, and you want to be prepared to handle it. But now we're using data, and we're making changes to staff to real patient volumes based upon that data. The FY27 budget of $16 million is $11 million below the FY26 projection and below all prior years on this slide. This reduction, along with the traveler expense reduction, is planned to reduce expenses by nearly $25 million from FY26. At the start of this presentation, Dr. Leffler talked about our organization and its importance to Vermonters. He also touched on quality, affordability, and improvements we've made. I spoke then in my sections about revenue and expenses, which are also aligned with affordability. In the next section, I want to talk a bit about access. I'm pleased to share the graphs on the next slide and what they mean for access. This work has been underway over the past several years, and many people have been involved to make these improvements happen, including our Chief Medical Officer. On the right side, you will see a length of stay and how it has improved. We budgeted a length of stay of 5.87 in FY26, and we've been able to make improvement beyond that in our current year, although we are in what I would consider the low lull, and we expect the numbers to come back up as we go into the fall. But we are budgeting continued improvement into FY27 with another 0.2% reduction. So what is impacting this? How are we making these changes? It's about data and education. Our success in reducing length of stay has come from consistent data sharing and education. We've made significant progress over the past 4 years. We've been sharing length of stay data specific to diagnosis to show where we need to improve. Additionally, we've been working with several community resources like nursing homes and home health to find proper placement for some of our long-stay, non-acute, or post-acute patients to ensure our beds can be utilized by patients in need of acute care. We have had past presentations to this board that reflected more than 80 non-acute patients in our hospital beds. Now there are days when we have single-digit non-acute volume. So if you look on the left side, it all begins to come together. We're able to see the same or more patients in fewer beds as the result of more appropriate lengths of stay and proper placement of our patients. This also goes back to being able to staff more appropriately, which ties back to the budgeted reduction in premium pay and travelers. And if you look at the case mix, you'll see we're caring for patients that truly need the level of care provided at UVMMC. Length of stay impacts all the goals around access, quality, and affordability. On the next slide, you're going to see where we've been placing our focus in that care of our patients. You're going to see we have been placing our focus in clinical FTEs and reducing our non-clinical management FTEs. As we focus on access, you're going to see in the next slide that where we're focused on is really about schedule and productivity changes. In addition, we're extending hours and have been in our OR and cath lab to try to meet our patients' needs. And the next 2 slides will look a little bit familiar to you. The overall clinical productivity for a medical group was reviewed in Monday's presentation, but this slide and the next one draw focus to the opportunities specific to University of Vermont Medical Center. This demonstrates we have work to do to get more services into the green, improve productivity, and increase access. The next slide demonstrates the financial impact and the importance of achieving the expense reductions brought forward by A&M. You can see the total expected impact is $18.9 million, and the savings at University of Vermont Medical Center are expected to be $12.4 million. So we are all connected on this and agree about the importance of making these changes happen. On the next slide, as we start to wrap up, I've listed some risks. The risks here could be for any hospital in Vermont and should be considered for all hospitals. Our budgets were created prior to CMS final rule, and as the risks suggest, there can be rate differences. We are seeing a slight difference in the final rates. I've not yet had the opportunity to determine the impact yet. But in addition to that, we've listed items here that, again, are not unique to University of Vermont Medical Center or University of Vermont Health and should be considered for all hospitals as we all continue to face inflationary price increases on our supplies as well as drug prices and our labor needs. Thank you for your time, and I'd like to hand it back to Dr. Leffler for the final part.
Thank you, Judy. So to summarize all of that, the budget that we're presenting for 2027 is intended to continue working towards improving access and qualities for Vermonters who seek care at UVM Medical Center. We believe this budget, as submitted, does help improve affordability for Vermonters seeking care. There are significant losses in the budget that we presented to you, and it will require other significant expense reductions over 2027, which we are committed to. I was going to finish with, for UVM Medical Center and UVM Health, there's still extremely difficult work in front of us. We're committed to doing it. It's going to take time. It will take collaboration. And the decisions are only going to get harder as we get down to the ends of what we have to do to get our expenses in line with our revenue. And so we're committed to working with the Green Mountain Care Board, our legislators, and our communities and staff to do the hard work in front of us. Thank you.
Thank you very much for the presentation and overview. A lot of good work being done, and we recognize the challenges you're facing, and thank you for taking them on. I'll turn to the board members for questions, and I'll start with Member Walsh and then Member Teachout.
Thank you, Chair, and thank you for the presentation. And I'll second Chair Foster's note that there are good trends here. That's good to see the progress. It's hard work. We appreciate the hard work and the collaboration. I have a handful of questions. The commercial rate increase of 0% is good. It's favorable, but it sits across atop the largest cost base. I appreciate you talking us through the cost changes that happened between the 26 budget and 26 projected, and how that flowed into the 27 budget. It's not yet clear to me. So I guess this is a question. Could you help me understand which of the costs that are part of the variance from the 26 budget to the projected are expected to be structural and persistent versus those that are temporary and manageable? Could you help us understand that, please?
Thank you for that question, Member Walsh. In the presentation, I was attempting to go through and isolate some of the areas that are going to be the toughest to achieve, such as based upon the care we deliver in our cancer care, our infusions, those drug costs are plaguing us, but it's important work that we do. And there's wonderful outcomes that we are seeing. Some of our melanoma patients are seeing extraordinary positive improvements, but those drug costs are going up significantly. So that, I think, is going to be the most difficult challenge for us. Another difficult challenge will be in terms of our staffing and ensuring that we look at our models, we look at how we're delivering the care, and how do we ensure that we're balancing quality and safety with cost. Areas that we're really focused on improving are things that are in our supply chain. And that's what I mentioned about going ahead and what I call front loading improvements that we are going after in FY27 of around $11 million improvement in our supply chain. It doesn't mean we'll stop there. Those are the recognized areas that we think we can make improvements in, but that it will be a continual process. Dr. Leffler, would you like to add anything to that?
Yeah, I mean, I'm going to go to higher level because Judy actually has much more knowledge on the fine detail. We're looking at every expense that we have, Member Walsh, and trying to figure out, are there dollars we can drive out of that expense? But the vast majority of our expenses, more than 60% of our expenses, are our staff and benefits. And we talked about this extensively on Monday. We're doing lots of work there. There's unfortunately more of that work in front of us. We're trying to do it as carefully as we can so we don't break things. And we're trying to do it in a way that preserves as much access and service to our patients as we possibly can. So the things around the edges of that, you heard some of it's premium pay, it's special pay, it's driving more expense out of shared services where we can, it's supply chain, it's pharmacy. All those things are ongoing and they will all help. But the biggest expense that we have, and the only way we're going to get $43 million more of expense out of UVM Medical Center, unfortunately impacts people.
I understand that, and I understand the difficult work that you're doing in that area. I'd like to follow up, jumping ahead with my questions to the pharmacy. I'd like to understand the net economics with pharmacy. I understand that there are cost increases, but there are also revenue increases. And could you help us understand the net effect of that on UVMMC's expenses and margins?
Member Walsh, can I ask for clarification in terms of, are you speaking of our retail pharmacy that is in our other revenue? Or are you speaking of our pharmaceuticals that are used in direct patient care?
Yeah, that's a great question. And it's honestly more detailed than I know how to separate. I'm interested in all together, the net effect overall.
So the drugs that are used in inpatient care are a part of the total care that's provided and the total bill that is ultimately issued for the care that is provided. In regards to the actual reimbursement for that, we have seen reimbursement go down. We do have the limit set by Act 55 on what our charges are. And sometimes those, I believe at our CVMC location, sometimes the reimbursement is not actually able to cover the cost of the drug. And certainly provide additional information on what we're seeing, where we're using drugs internally to care for our patients. Happy to follow up on that. Regarding our retail pharmacy, back in our presentation, there is a net number that we will get to you. That other revenue section is really what is keeping our losses from being worse. So the retail revenue and the retail expense, the expense itself is more than covered by the revenue. So the elimination of the expense itself will hurt the actual bottom line, our actual losses, versus helping it to remove that expense because it is fully covered by our revenue.
And all I'll add, and this is, from a doctor's perspective, I think it's a huge risk to all hospitals. Many, many hospitals across the country are surviving on pharmaceutical revenue. UVM Medical Center and UVM Health fall in that category, and there's constant federal threat to that. And so we watch it carefully. It is subsidizing the care we provide, and other changes to that revenue will add to our losses and expense reduction required in Vermont. I don't love it, but that's the reality of where most hospitals in the country or AMCs find themselves.
Yeah, I appreciate that. I appreciate both responses, and we too see those changes. And that's why what I'd appreciate going forward is more help in your submissions in seeing the net, because we hear a lot about the increase in costs, but we also see a lot of the revenue that comes from those. And it's difficult in the way that the budgets are submitted to us to identify the true net. And we do not want to be in a place of cutting too deeply or pushing too hard. And as you mentioned, Dr. Leffner, breaking things because we don't have a good enough view into what's happening. So that type of information would be helpful to us.
Certainly, we attempt
Yep.
to
Yep.
we attempt to do that for our retail.
Yep.
It is much difficult on our inpatient, our infusion, because it is part of the whole care that is delivered. But directionally, you can see our commercial revenue is certainly below budget. So you're seeing in that environment of care delivery, we're actually losing money. And as Dr. Leffler said, the retail side for many hospitals is what is providing a bit of a lifeline.
Right. Yeah. Okay. Thank you for that. And again, I appreciate the efforts that you're making and the collaborative nature in which you've come into this, and just helping us see better the net with the pharmaceutical costs and revenue would be really helpful. My next question, over the years that I've been on the board and also looking back, the record shows that there are typically large variances in the budget and the projected or actuals for expenses and revenue. And back in FY24, we required UVMMC, the order says within 3 months, to submit a plan to reduce costs and control expense growth. And I'm wondering if you could help us understand how that order impacts today's budget. What were the recurring savings identified that carry through so that those would be visible? Because from where we sit, it just looks like operating expenses are going up. We order a reduction, but the next year they're higher again. And so, again, more clarity on what's happening there. Could you help me understand that?
I'll start. So I have to be totally honest with you that 2024 feels like 2 lifetimes ago right now. And I know there was a lot of different plans, and Rick may know in his head what we called it in 24. We did some big plans. I can't remember if it was the path forward, or we had some different ones.
That's right.
And so I know there were savings there. If you're willing to have Rick speak up, I can probably give you some detail. I see him on the
If you
screen. Yeah.
Yep, I can see them, and of course, I don't mind hearing from Rick. You could also submit them to us if you wouldn't mind that. I don't mean to put somebody on the spot to think back like that.
I mean, one of the things I can tell you, because I hear it from the CFOs all the time, is that we do all this work on expense reduction and then inflation just swallows it. And so you do all this hard work and you save what sounds like a big number, $80 million, $100 million, and they say, yeah, Steve, but the inflation was 130. And I hear that consistently. So we can do what you would like. If you want, it looks like Rick might be prepared to give a little answer, and then we'll obviously give you more.
Yeah, remember Walsh, as I said on Monday, we can break down kind of what's transpired over the last few years, both in terms of inflation, as Steve said, but also just volume growth creates new expense. So being able to show you the things that did increase and then the things that did decrease costs so that you have a much better sense on what's happened the last few years. And we'll obviously be able to, it'll have to be, fairly high level, but we'll give you a much better sense on what's transpired.
Great, I appreciate that. And I do understand the effects of inflation. And that's what makes this so difficult from a regulatory standpoint, and even more so from your seats, right? That we're trying to do our job and order these reductions based on the data before us. But there is growth occurring. And so how do we do this? What I'm thinking of is, how do I do this better? How do I better understand what's actually happening? I guess the second part of my question here is, could you tell me a little bit more, tell us, what's changing about the way that you forecast and monitor and manage expenses? There is this history of a large degree of variance, and that creates difficulties for us and for you. What steps are you taking to try to improve that process?
I'm going to start, but I'm going to very quickly hand it over to the CFOs. What I will tell you is, I have to tell you that when I hear that we're, close to 1% variance, I know that number's giant in Vermont because we're so big. 1%, we're making these budgets 16 months ahead of time. And we've had this question before at the Green Mountain Care Board. It really depends on how much data you use to drive the decision and how conservative you are in your estimates. When the CFOs are building budgets, I know Judy and Rick extremely well. They're trying to only count on what they really think is going to come in or really going to happen. And I've heard you before say, well, put a little optimism in there as well. I can tell you that with the $43 million loss, there's a lot of optimism in the 27 budget. We have huge risks that we could fall significantly short of only, or however you want to put it, of losing. We could easily lose more than 43 million. We put probably the most I've seen in my career here in the 27 budget. So it really matters how rigid they are in, are the dollars going to actually come in or not, and where you want to take risk. Do you want to take upside risk, or do you want to take downside risk in either? And most of my years, we've tried to be very conservative and not underestimate where we're going to fall. This year, there's a lot of things that have to happen for us to only lose 43 million. I'll stop and I'll hand it off to Judy. Excuse me.
Rick, do you want to talk about the kind of the system take on our budgets? And then I'll certainly speak to UVMMC, because, we're all coming at this together to try to achieve affordability and management in Vermont.
Yeah, I don't have too much more to add to what Steve said. I mean, we are doing the budgets well in advance, and so we're basing on, the information that we have at hand. Essentially, really through April is really the last kind of piece of real data that we have to kind of build our budgets that started in October. So, we're basing everything from that point forward. In the budgets, we do assume, as you've seen through the presentation, some improvement in access, which, impacts revenue. We're assuming a certain payer mix. We're assuming the expense reductions that you've heard about on Monday, and Judy went through in her presentation. So we're making assumptions beyond just the current data that we have. But we are doing them well in advance.
Is there a formal process improvement method being used to monitor and improve the budgeting process?
Yes, every year we have a debrief after the budget process. So all the CFOs, the budget department staff all get together to kind of review and with the presidents, how did the budget process work? What did we learn? How can we improve? How can we become more accurate in our estimates? So we do that every year following the budget process, and then we get together in January before the start of the following year's budget process to talk about what we've learned and what we can do to improve.
Could you describe any measures that are part of that process, not the end result, but the measures that document the steps in the process that would ultimately affect the output? And specifically, I'm interested in improving or decreasing the variance.
So one of the things we look at is the variances that we had in the prior year. And one of the things that you heard Steve talk about on Monday is in last year's budget process, we did make some assumptions, essentially some pretty significant budget plugs that we had to do very quickly. That as you're looking at the results this year, particularly when you look in the expense section, is creating some very big variances when you're looking from one year to the next. So we made based on that, that large variance, we made, through Steve's direction, we made the commitment. We weren't putting any, budget plugs, if you will, into the budget this year. If we weren't confident in and had a plan for an expense reduction item or an access improvement, we didn't put that in the budget. So we do use the variances from the prior year to help inform how we build budgets going forward.
Is there an executive in charge or responsible for the process improvement aspect of budgeting?
Yes, that's me.
And I'll add to that from a facility lens. We certainly look throughout the year as we're doing our explanations for variances to look at what did we miss, what did we not count on, what did we over budget. So if there's something that is over budgeting, that does not carry in to our future years. We adjust that line. We actually go through every department's budget and we create what we call a baseline based upon what we're seeing in current environment. And then from the baseline of what's happening today, we have meetings about what can be improved, what's going to change, what are our leaders seeing, what are our staff seeing in terms of changes within their service areas that will impact our next year's budget. So it's very collaborative in that way, but we do not carry forward what we'll call the variation and the noise that has been in a prior year's budget. It's certainly difficult, and this year I will say that the $43 million loss, if we were being more conservative, would certainly be larger. However, it is important that we seek the improvements and not just say this is what the number will be. We're really driving to improvement, and Dr. Leffler has really called upon all the hospitals and all the departments to be accountable to their budget and achieving, because the losses that we receive and feel in University of Vermont Medical Center and any of the hospitals in the state impact patient care.
I don't have any doubt that everybody's working with best intentions and extremely hard. The reason that I'm asking so much about variances and this point in my questions is that there's an over 8% variance in the operating expenses that were from budget to projected last year. And those operating expenses are growing still further in the coming year, while the operating margin is negative. And so I'm trying to understand, there's a lot of variance around those numbers potentially. So if the volume and the pharmacy margin, the workforce changes, the savings, the reimbursement, the transformation assumptions that are in your budget, if they underperform, what can we expect as corrective actions go in 2027?
So I'm going to start, and I do want to say that as we got our budget orders for 26, there was a significant change in our budget, and then what our orders were, and then we had a huge issue with, we knew our revenue was going to drop significantly more. It dropped 120 million or so from Act 55, and there was another 100 million coming out. And we did what I've seen us do many times. We said, okay, we have to get expenses down by this much to still earn a positive margin this year. And the truth is, some of that wasn't realistic for where we were last fall and this spring. And we're doing the hard work now, but it started too late to achieve those expense reductions. That's what we call a plug. And when we were putting this budget in, that's one of the reasons you see this huge jump, that we did not deliver, or we were unable to get all of those savings we needed in the time that we had for this budget. the unfortunate answer to your question is we have to get back to having our revenue exceed our expenses. And over 2027, we will continue to do what we have to do to bring expenses down to meet that. That scares me, but that is the answer, Member Walsh. Our expenses are going to come down this year to the point where our revenue exceeds it. We're going to do as much of that as we possibly can without impacting the care we're delivering across this region. You have my absolute word on that. But it isn't clear to me as I sit here today that we'll do all of that without impacts to patient care, bigger than what we've already had to do.
So my final question on this topic, what is preventing the first response from being a higher commercial price in coming years, or a reduction in local or needed services? What are the stopgaps in place to prevent that?
I think it's what was on our last slide. We will work with you. We want to partner with you. I mean, you are a regulator, so you do set our rates, but we will come to you with what it looks like where we're at and try to work with you as we can. The last thing that we want to do is reduce any services. And so I think we'll squeeze out every penny we can out of everything possible first. And then if we're to the point where it looks like we'll have to do some reductions, we will come to the Green Mountain Care Board, AHS, our partners across the state, and lay out as clearly as we can where things are and what we think we'd have to do to be able to prevent that. Does that answer your question? I hope. Okay.
Yes. Yes.
Member
Thank you.
Walsh, if I can add to that,
Yes, ma'am, please.
in the in one of the meetings we had this week with the this year with the Green Mountain Care Board staff, and we were privileged to have you, and I believe we had a member teach out as well. One of the things I discussed was, revenue is easier and faster to reduce than expenses, because expenses are part of your DNA and how you deliver care. So it's really about a runway. We're committed to getting there. Affordability is really important, as well as quality care. So we're committed to getting there. The runway in a single year is too short to make the complete adjustments, which is why the board has asked for basically a 3-year, how are you going to get to these numbers over the next 3 years? And we are focused on that. We will not lose focus on bringing down our cost of care. That is high on, I know all of my peers' list. It is something we discuss now within our daily operations, and we're monitoring our daily cost of care. And I present that information to all of our leadership to raise awareness of how costly it is to deliver care in an academic medical center, but what we can do to improve that. And so we're bringing that information accountability throughout the organization, instead of it just being a leader-led initiative that, as you know, can have poor results on a long scale.
Yeah. Okay, thank you. I want to shift a little bit. In your budgeting documents, you present shared services as an efficiency strategy. Could you tell us how much savings is realized and recurring from the shared services versus avoided growth or revenue improvement or vacancies not being filled, or some future objective? What's being saved in this budget through shared services?
Rick, do you want to take that?
Yes, I'm just going to pull up the slides from, if you just give me a minute, just pull up my slides from Monday. And the savings that we talk about, Member Walsh, are true. Like, it's not cost avoidances. We cut the cost and it continues forward. So it's not a theoretical cost reduction that we put into the or cost avoidance that we put into the budget. So we have, so total shared services. So this isn't just the This isn't just the impact on the UVM Medical Center, but we can give you, we can break that down for you. So the total amount that we budgeted in 27 is $21 million.
And I would appreciate a breakdown. What I'd like to understand is for the largest components of that, maybe the top 2 or 3, what work or cost actually disappeared? And what's that measurable amount that we could follow through for that? I'd appreciate that. And you can follow up. I don't expect anybody to be able to answer that now. And for that type of monitoring, would it be you, Rick, and Judy, who are responsible for those calculations?
Yes, we can work with the staff and just include some additional information on our monthly submission so that the board could get that.
Thank you. Of the decisions going into creating the budget, a sizable portion of the increased operating expenses are due to provider compensation. And that's not a bad thing at all. What I'm trying to do is find a thread between the increase in provider compensation and the documented community needs and your community health needs assessment. So could you help me see a line between the increase in provider compensation and the access issues, the documented very high ED wait times, the mental health priorities, the other issues that are identified in the community health needs assessment? Where can you help me see alignment between that operating expense increase and the community needs?
Dr. Harrington, you're not on my first page, but I know you're here. Do you want to start on that one?
Yeah, let me take a first shot, and I'm gonna go just a little bit broader, Member Walsh, and talk about our process for how we assess whether we need another provider in a certain area. So the medical group is referenced in the A&M work as well. The medical group has a committee that looks at each new position that comes forward when we think that we either need a replacement position or a new position. Historically, that's just been for physicians. Recently, we took on both locums and APPs. And we look at demand numbers and we look at productivity of the group to try and right size whether we actually need a replacement position. And if we need a replacement position, what level that is, whether it's an APP or a physician. Once that position gets approved, we then start obviously to try and recruit into that role to just meet demand. That's the high level where we go to where we're going to recruit. I'll come to the community health needs assessment in just a second, but as far as compensation goes, we spoke in the UVM health budget hearing about our desire to shift a little bit of how we're doing compensation to align with productivity. Liaison team also spoke to that. But in general, salaries and costs for APPs and for physicians are really just tied to national markets. And so when you look at national inflation, obviously there's an increase in the cost of the salary. So you've got kind of a double increase when you look at overall provider costs, because we know that we're short of meeting demand. we're going to get closer through the A&M work, obviously, by increasing our productivity for providers, but we also still know that we're short providers overall in certain areas. So when you increase your, to meet that demand and you're tied to a national market as it's climbing, the number continues to bloom. As to the community health needs assessment, from my perspective, part of that is, the strategy of where we go. Like you mentioned, ED waiting times, mental health challenges. And I think if you look at our areas where we've tried to grow strategically, they have been in areas to try and meet specific needs of our community. Primary care is probably the area where you'll see our success and our growth of trying to meet needs. And then I also want to make the note that sometimes it's not just providers that actually get to making the impact that you need. So emergency department wait times, mental health needs, particularly for those that may or may not need inpatient services. It's, obviously it's not just providers, it's also space and, availability of beds. So hopefully that helps some.
It does, and I appreciate that. And it's a complicated topic, right? Because there are, when there's unmet need or access difficulties, there may be systematic process operations flow that need to be changed. And just adding more providers to a system that's dysfunctional won't make it function. And so, and adding those providers is a big expense. And so in many organizations, the addition of providers and the growth and access is strategically done to maximize revenue. And what I'm trying to do with my question is keep myself and us focused on making sure that the budgets that we're approving are allowing growth in operating expenses that are targeted toward the community needs. So I appreciate all the responses and looking ahead, what I've tried to do with these questions is ask from you for a commitment to future budget filings that help us draw a clearer line among the direct patient care expenses that we want to grow. We want those expenses spent wisely. There are fixed and externally driven costs that we all have to learn about and understand. There are also administrative, general, and variable expenses, and where those can be modified and save patient care and save work done for community need. That's where I'm asking for commitments from you to help us see that better. It hasn't always been easy to see.
We will commit to that.
Where there are costs or savings that originate from the system, would you commit to showing us what those costs actually, what costs were actually eliminated at the affiliate hospital or at I'm considering UVMMC an affiliate of the network at this point, or where the net savings can be found?
So I can just give you a very quick example. When I took over last October, between October and now, we've reduced over $10 million of leadership expense at the network level. And those dollars flow directly back to each and every partner hospital. So UVM Medical Center sees 65% of those savings, and each hospital, you'll hear Porter's percentage if you ask them. And so 10 million there. And that's only one example. It's just on the top of my head.
I've asked and you made the commitment toward helping us see a more direct line, and for a more concrete net savings from the network. Who would be the accountable person for producing those two analyses? Would that be you, Rick, and Judy?
Yeah, it will take some partnership as well with the staff, Member Walsh, which I'm sure we will have. So every month there's required information that we submit, and we can work with the staff to make sure that that we get you what you need to be able to monitor during the year, and our budget submissions going forward. Now that we have a better understanding on what you're looking for, we can certainly ensure that those are included in future submissions.
Right, and with those monthly meetings, monitoring the variance would be appreciated as well. Okay, I'll stop there. Thank you very much for answering the questions. Thank you very much for the commitments, and thank you very much for the work you're doing. And back to you, Chair Foster.
Thank you.
Great. Thank you, Member Walsh. Member Teachout?
Yes, thank you very much. I'm going to start with my pharmacy questions that I appreciate you addressing some of this in your presentation. I'm just going to show you 2 slides so we know exactly what data we're talking about. It's easier than just spitting out numbers here and there. So this first one is what UVMMC submitted in FY26 under other revenue. And I did highlight in yellow the 2 lines that I'm focused on, the 340B retail pharmacy program. And this shows the growth from what you projected for FY25 and what you were budgeting for 26. You were budgeting a 51% growth, which is pretty significant. And then down below in specialty pharmacy, you were projecting a 4% change in that year. Just to clarify, I'm pretty sure I know what retail 340B pharmacy is. Specialty pharmacy does or does not isolate the Act 55 revenue.
No, our specialty pharmacy, unless, and please correct me, anyone who, if I get this wrong, our specialty pharmacy drug costs, we are usually looking at, as I mentioned in the presentation, our refill of places like Kinney's, Walgreens, and our own specialty clinics, pharmacies with the high-end drugs that I mentioned coming on the market in regards to being able to provide those. Where we have a cap on it is based upon a health insurance PBM. So their pharmacy benefit manager and the insurance company sets the price they pay. So our charges are limited by what the insurance company actually determines that they will pay for a drug. So we don't have control over the reimbursement. And what we try to do is ensure that we have the ability to provide the specialty pharmacy drugs that are needed for the patients, whether they're for our patients or other patients within the state. So I hope that clarifies that really the pricing on the drug is not, on this is not dictated by UVMMC. We can't charge $1,000 for a drug based upon cost or any of those other items. I actually have a, which I think would be very helpful because this is a very complex area. I actually have a presentation that walks through how retail pharmacy, specialty pharmacy actually gets reimbursed. And it is based upon the negotiated prices that the insurance company sets with their PBM. And then that PBM then distributes that to anyone that has a contract to fill those pharmaceuticals.
Great. I look forward to seeing that if you want to submit it to the board later. I'm really talking about the numbers here. So last year you predicted or forecast that there was going to be 51% growth in 340B retail and a 4% decline in specialty pharmacy. This next slide is, let me get it to come up, what you just submitted with FY27. So instead of a 51% growth, you saw an 82% growth in the 340B retail pharmacy, and now you're projecting a 14% decline next year. And what you actually saw in specialty pharmacy, or you think will happen, is a 23% growth rather than the 4% decline. So that's, you know, a pretty big swing, and now you're projecting a 5% growth going forward. I'll take the slides down unless you want to look at those numbers. I'm sure you're familiar with them. But I would like you to talk about the differences there and what caused those enormous swings, quite honestly, in your projections.
Absolutely. And one thing I do want to remind all of us is that all of the expense in those categories are covered by the revenue and is not impacting our rate request, or the place that it does impact is supporting our other operations. In the presentation and in some of the notes for our 340B, when we built our FY26 budget, this was before the full enactment of the law that protected contract pharmacy. So it's really a timing between when we built our budget and then the law became enacted, and we actually saw an increase in demand. When we built it, we were not sure that contract pharmacy was going to be protected. So again, we talk about when a budget is built, and then you start it in January, you might have it in April, and then when you actually start your fiscal year budget in October. So significant
Can I
shifts
interrupt
there.
Can I interrupt? Wasn't the contract pharmacy law Act 55? It was all wrapped together.
Yes.
Okay, so you were projecting Act 55 revenue changes, but not contract pharmacy implications?
When we made the changes for our Act 55 was, I don't believe in our original budget, we did have to revise. And when we submitted that, I do think we had more clarification on what that was going to do versus the actual contract pharmacy piece. So that is certainly a fair question. And I will say that that was less on top of mind than the actual impact from the price changes of the Act 55 that had on the pharmaceuticals. And the other piece of it that I will say is, there is one thing to predict, but then there is the other piece that is demand. And we're seeing that in terms of both the specialty pharmacy and our contract 340B pharmacy. So in both of those areas, we are seeing increased volumes, and that's not a bad thing. It's good because we are ensuring that there's drug delivery for patients that need it. It does not cost the state of Vermont or Vermonters any more than getting their drugs at Kinney's or Walgreens. And many of those relationships we actually work with our local pharmacies to provide those drugs, because it's always patient's choice. Patients have the choice to get their prescriptions filled wherever they want. So we're trying to meet them where their needs are, and remembering that we don't set the price or the rate. And when we deliver those pharmaceuticals to the patients, whether directly or indirectly through one of our local pharmacies, the funding that we receive back, that again is set by the insurance, that funding stays within the state of Vermont. We're not sending that out anywhere. So that is directly helping deliver care at University of Vermont Medical Center that otherwise, without that revenue, we would be requiring and needing more financial assistance. So I hope that helps to understand that piece of it. And I'll be honest, at the pace in which the specialty drugs are coming on the market, that's where 70% of the growth has been. I don't know that we've predicted well for 27 just because we don't know what's coming. And we do report it every quarter, and I'm happy to break out on a quarterly basis that we submit to the Green Mountain Care Board. We can do that slide that shows other revenues specific to retail and 340B so that you can keep track of where we're running.
So you did attribute some of the change to increasing volumes. Are these increasing volumes because of more scripts or increasing volumes for other reasons?
Every prescription has to have, or every drug that's filled has to have a prescription. So, but it is not just a prescription because those are filled by, again, outside pharmacies and inside our four walls as well. But it is also based upon the type of drug. As I said, in the specialty pharmacy area, you're seeing patients that used to be on 2 drugs that may have been lower cost, and now they're on a more effective, higher cost drug that is having better outcomes. So the level of care provided by our providers and other providers in the state are what indicates what type of drug is actually prescribed for that patient.
Sure. And I'm not a clinician and neither are you, but for many drugs, there's multiple alternatives. When the provider is choosing, are they aware of which drug has the least overall cost for the patient or which drug has the largest margin for the hospital?
There's no discussion about margin for the hospital because again, in these arenas, those prices are set by the insurance companies. So in the 340B and in the retail arena, the actual, I'm trying to remember what it's called, basically the drugs that are available are determined by the patient's insurance company. We don't have any influence or impact on that.
Right, but UVM Medical Center or Health Network has a pharmacy and therapeutics committee that's making a formulary and prescribing policy recommendations for the providers at all of your facilities, correct?
For the care directly provided to our patients, for our what we'll call our inpatient pharmacy, but not for retail and not for 340B. Those are all determined by the insurance. So they produce their own formulary and say whether a drug is approved or not. We don't have any control or impact or influence on that, just like we don't have any control, impact, or influence on the price that they pay to actually fill that prescription. So we are not involved in that process at all. So think about a Cigna patient outside of us that is insured separately from any of our own employees. Cigna determines what formulary they will actually use. They determine the price they will pay for a script to be filled. And then that is executed typically through a third-party administrator, a pharmacy benefit manager, and anyone who fills that, whether it is UVMMC, Walgreens, Kenny's, they have a set price that they get paid. They don't have influence on what gets filled, when it gets filled, or any of that, because that is not set internally. That is an external decision. Regarding the drugs that we use internally with our own formulary, we certainly look at our P&T committee to give our providers information on, what is therapeutically appropriate and if there are alternatives. So if a provider is prescribing something that goes to our pharmacy and they believe that there is an alternative that is less expensive or has more therapeutic benefit, they may weigh in on that. But there are a lot of individuals in the P&T committee, so it's not an administrative decision or even just a pharmacist decision. It really is made up of clinicians.
Okay,
I'll just
so
add,
I'll just, oh, sorry.
so I'll just add for P&T, and I want to be honest, I haven't been to P&T in a little bit. Every time I ever attended P&T, first was efficacy of the drugs and the need and how we would do it. I have been in P&T discussions where the reimbursement didn't cover the cost of the drug. I've never been in a single P&T meeting where we talked about using this drug improves the positive margin. Dr. Harrington, you may have been there more recently than me. I've only seen the opposite where we said, boy, we're losing our shirt, but we have to do this because it's so important for the patients. So our P&T committee is really driven around efficacy, and there's a less costly alternative that works as well. We do that often. Do you want to add anything, Ramsey?
Yeah, I think we spoke a little bit about the work that P&T did recently with biosimilars. And so to use a specific example, denosumab is a drug that we use to, I think, treat osteoporosis. There's a biosimilar that's out there. As we mentioned, it's really about the cost of the system. I think there's a question about, is it cost of the patient or cost of the system? In this particular case, it's what we can acquire the drug for with equal efficacy of the drug itself. And ultimately, the intent is to pass that savings on to the system and therefore total cost of care. So when pharmacy and P&T get to, this is something that we should recommend to the providers, we then get a list of all the providers that prescribe these medications, and a communication goes out between me and our lead pharmacist for the system to those providers to say that, we're making a decision to use this biosimilar drug to pass that cost on. One other thing that I'll mention, because I think part of your questioning is trying to get to how do we take pressure off our people that are having to pay for these medications. I will say in clinical practice, over the last several years, we have embedded pharmacists in most of our clinical areas. And so when I work clinically, we have a pharmacist that's in the ED, and when we go to prescribe medications, the ED pharmacist, as they're reviewing what we're doing, will help inform in real time, and then also in our group meetings, like alternatives and what the actual cost of the drug is for the patient. And in the moment, if there's for example, an oral alternative that works just as well as an IV, they'll make that change for us or tell us that they're making that change for us. And at the time of prescription, if we're looking at, I don't know, antibiotics that are going out the door, they can tell us, what the cost is of those drugs and help inform it in the minute. So I'm using those two examples, but we do think about this on the clinical side of the house.
Great, thank you. So I'll just return to the numbers that I showed you earlier. Those were, I believe, unanticipated revenues far in excess of what you had originally projected. In your attachment A, under FY26 impacts not budgeted, you say you underestimated the impact of Act 55 by 9.3 million and are offsetting your revenue reduction, or the amount that you believe you need to change in order to meet our guidance. Did you net any of that against these unexpected revenue gains also in pharmaceuticals?
There are two different categories. One is other revenue, which is where we have seen the increase, which is helping to support the regulated services in our commercial net revenue. So in the bottom line, yes, that 43 million is absolutely supported. We cannot pass along retail revenue savings directly to our commercial negotiations. Everything that we bring in for patient care and through our retail pharmacy is certainly considered when we look at our bottom line and what we need to take care of our patients. In terms of the regulated portion, we are in the grid, you can see the commercial NPR that we are regulated by, and that is what we're referring to in the Act 55 that is impacting our regulated commercial net patient revenue. So the two are not blended at the commercial level. They are blended further in our P&L, which is reflecting the $43 million loss. But the two are different categories, one being other revenue and the other piece being commercial revenue.
Okay, so to return to the attachment A, you also say additional rate reductions at Blue Cross were above what you anticipated, so you're netting 20.9 million against it. In past budgets where negotiations have gone the other way, and a payer may be paid more than they anticipated, did you net that out against the budget that you presented to the board?
All of the information flows through year to year in terms of our revenue and whether it is a sustained revenue item or it is something that is a one-time. So
And
in
those-
terms of, go ahead,
Sorry,
Steve.
finish me. And those overages were enforced, remember, teach out. And so if we undercalculated on something when we negotiated with our commercial insurers, there was enforcement action by the Green Mountain Care Board on those commercial revenues.
Well, not always.
True.
Right?
True.
And sometimes partial enforcement. So in those instances, did you count the revenue that was over what you anticipated against your commercial request or your any other request, net patient revenue request for the following year?
If it's recurring revenue, it is included in our base. If it's one time, it is not. And the one thing that is important, even during the times of enforcement, is that that revenue that is enforced is not net of expense. So it carries a larger expense base into the future based upon if we were 10 million over in commercial net revenue, the commercial net revenue was enforced, but let's say, and I'm rounding numbers, let's say the 8 million of expense was left for coverage with the revenue being removed. So it is important to recognize that the care that is delivered to patients. It's actual people who receive that. And yes, there are times when our volumes are different or our payer mix is different, or there are times when some of the diagnosis, let's say cancer, we're seeing more cancer patients in a year, that it is going to vary. And especially at our scale, it is really hard to know what is going to come in the door. So we use a baseline of what have we been seeing? Do we have any indications that that's going to change? Do we have any indication it's going to go up or down? And that's the methodology we use. I have seen in other states, I have been able to utilize commercial information from our commercial payers to understand what their patient complement is going to look like. If they're increasing their members' lives that they're covering by 500 based upon a new business coming in, they would feed that information at that time, and we would be able to say, okay, we might have, let's say, 80% of those 500 coming in, and we could adjust. I have not seen that type of work done here. I don't know how the commercial insurances determine how many lives they're going to cover and if there's going to be more lives covered or more utilization. So I think data sharing would be really helpful to be able to understand the population that's covered by our commercial payers, to be able to better predict what type of care they're going to need. And I think that in itself would certainly help be able to kind of take some of the noise out of our budgets.
Okay. I'll just jump to the next one you added in your FY26 impacts budgeted, the post-budget CT and RAD oncology code changes. I understand that Medicare changes coding all the time throughout the year. Would you agree that it happens both in the upward sense and in the downward sense, revenue-wise for the hospital?
It can. What was unique about this year is that the reduction of the codes, moving from many to few, did not cover in the reimbursement for the codes that were left, all the services that were performed by the larger count of codes. So we didn't have a substitute, and that was unique. I had not seen that before. So that is why we're drawing it out as a variable that we're seeing. Now, if that trend continues, where a reduction of what I'll say the many to the few codes continues, where the reimbursement is not improved or at least the same as it originated, we'll bring that forward because that again will impact and probably impacts us based upon volume more than it is other hospitals in the state. But that was an important factor to bring forward because of how different it was this year.
Okay, so you're saying it's the scale of the change and that's why you brought it forward?
The change itself was quite unique, again, and a point where you would have 4 codes based upon, just giving an example, if you had 4 codes originally to perform a service, and with those 4 codes, each one of them represented a piece of the service provided, what happened was you ended up with 2 codes. And so let's say the 4 codes were worth 100, the 2 codes are worth 50. You're billing the 2 codes, but you are performing all 4 services. So what we would normally see is when you convert from those 4 codes to 2 codes, the reimbursement actually goes up to cover all 4 services, and it really is just a matter of reducing the number of codes. This was unique because that did not happen. And that's why we brought it forward, is because reimbursement was reduced as the reduction in codes occurred. And that's, again, that was very unique and very different. I've not seen that before.
Okay, but Medicare changes codes all the time. They go from time-based codes to intensity-based codes. They move from adding modifiers to taking modifiers away. There's a lot of activity in the coding side. Would you agree?
Absolutely. And usually with that, we see what they have done to shore up the reimbursement with the actions. Usually it is for clarification, for ease, or it can go the other way where there's an additional code that's added for more completeness of a medical record. This situation was unique and did not follow any of those rules, in that the codes that were taken away did not result in the same reimbursement by the remaining codes. So again, that is what is different. There is, and all through my career in healthcare, I've seen those fluctuations of codes. And you may see a little bit of a decrease in, let's say, a lab payment, but nothing to the extent of what we saw in those areas this year. So that is why we pointed it out as a current and also kind of a flag for this may be a direction for the future and we will continue to monitor that.
Okay, and my last question is about board restricted assets. I didn't make a slide for this, but I noticed the difference between what you submitted in last year's budget and what was submitted again in this year's budget. Last year, you projected a 6% increase in board restricted assets, and now that projection is 34%. So it's about a $258 million difference. Can you talk about why that happened?
I will actually be happy to provide you with some detail about that, but I would like to submit that so I can make sure that I'm not pulling numbers that you're not referencing. So happy to follow up with you on that, provide some more insight.
Okay. Thank you. That's all the questions I have, Chair Foster.
Thank you, Member Teachout. Appreciate it.
Thank you.
Thank you. Why don't we take a quick 3-minute break, and then we'll return with Member Merman's questions. So just a quick 3-minute break. Thank you. Okay, we can resume our hearing. Dr. Merman?
Just waiting for everyone to come back. All right, so I'm going to start with just a quick statement, and then I have a bunch of questions. But basically, I really appreciate moving from this cost shift budgeting perspective to an expense management perspective. I think this is long overdue. But I think given the legacy and given the legacy of assuming cost increases must be met with revenue increases and not operational improvements or expense avoidance, I would expect this to take years to unwind due to the lack of attention on these areas. The notion that increasing commercial prices gives our local nonprofit more resources that they can invest back into the community must be balanced by the evidence that increasing commercial prices reduces jobs, access to housing, and really impacts livelihoods. And when I say efficiency, I think sometimes this term gets a little bit, different people have a different view of this term. Sometimes I feel like people think efficiency means just less people, more work for less people. But I also really think it means operational improvements, making work smoother, getting rid of these terms like friction and sludge, retaining your employees so you don't have to hire new ones or travelers, hiring medical assistants so your clinic providers can be more efficient, getting the data to understand what is happening, cleaning that data, checking the data again, reviewing the data. A culture of continuous improvement in delivering patient-centric care, a culture of continuous improvement in quality, a recognition that long wait times, long throughput times, long lengths of stay are not just someone else's fault, but they're quality issues that impact patient care, safety, and access to needed services. So I do think the tide has turned on this, and I really appreciate that. But I also think it's going to be a long journey. I think Dr. Leffler mentioned this, that there's and Ms. Peak Lee as well, that the revenue impacts trying to reduce prices quickly is much faster than the expense management impacts, the cost avoidance, the expense avoidance, the operational improvements. So I really appreciate the attention to this and the change in focus this year. All right, so I have a bunch of questions, and I think I'm going to start with some of what was discussed in some of the initial testimony today in the slides. And one area was, I think it was Dr. Leffler mentioned price reductions in areas, mentioned imaging, but there was also primary care, I think of 52%, and childbirth services of 25%. And one thing that I think about this is those areas are typically thought of as money losers or already requiring cross-subsidization for them to be financially viable. And does reducing prices in these kind of essential services that are generally thought of as under-reimbursed increase the risk of elimination because of their worsening their financial losses?
It's an amazingly great question. That is not our intention to not have primary care or OB services at UVM Medical Center. I have to tell you, Member Merman, that I really think about all of the revenue that comes in rolled up into one big bucket and how can we use it to serve the most people possible for the essential needs they have. And there are a wide number of services that we lose money on, a much smaller number of services that we actually make margin on. Those support all the rest of the mission. So I was not in the negotiations day to day with Blue Cross for how we came to those decisions around OB services and primary care. But my understanding of the negotiations was we looked at areas where we thought we were high priced and tried to bring those down some in those areas to start that work. Rick or Judy, I'm assuming that's how those were called out. They were higher than what we felt was appropriate for the other reductions, to try to balance that out over the overall 12.4% reduction. Higher in some things, less in others.
That's correct.
Do you ever, so a common strategy in commercial negotiation, from my understanding, is to lower prices in areas where you have fewer commercial patients or lower commercial margin, getting the Medicare, Medicaid prices, you don't want to go under, of course. And then on an aggregate level, trying to raise prices on things like imaging, lab, orthopedics, drug infusions, which I think, has been the history of price increases at UVM. in the context of strategic pricing to try to maximize overall commercial revenue growth. So I guess when you lower prices in the areas that are necessary services, I appreciate that you know, with high deductible plans, you're trying to reduce the expense to people. But we see, I guess, would you make a commitment that when we see service reductions around Vermont, we see this in areas where hospitals are saying we're losing money on these services, but they're low price services to begin with. Will you, I guess, make that commitment to cross subsidize these essential services, even if you're losing a lot of money on them?
So a couple things about your comments. I do think for everything we talk about, Vermont is a bit different in how you assess commercial revenue impact, because we do have commercial revenue overall caps and rate caps. So it has some impact that's different than 49 other states. And I want to be careful in that as we bring our expenses down this year, we're going to have to look at everything that we do to get our expenses down under the revenue that we're going to bring in 27, 28, 29, and 30. And so we will look at everything on that, and we will partner with the Green Mountain Care Board. We heard the same question in a different form from member Walsh. I'm committed to UVM Health doing every service we can possibly retain for Vermonters here in this state. But we have hard decisions in front of us. So I'm not trying to avoid your question. I'm trying to say that we have to look very, very carefully at, is there a partner in the state that could do it cheaper? Is this a service that might be better delivered by someone out of state, by Dartmouth or Albany? We're doing low volumes of it, even though we're subsidizing it. But that's our last resort, Member Merman. That's the last thing that we want to do. But I am concerned those decisions are in front of us.
Yeah, I guess the last comment you make gives me pause, because I think, you know, this is potentially what happened with inpatient psychiatry a couple of years ago at CVMC, or you know, obstetrics at Copley, when a service becomes such a drag on the overall margin, it seems ripe for elimination. So I would just be mindful of. I would ask you to be mindful of considering the price reflecting. It's a tough balance, right? I mean, you pointed out in your comments that you know, high deductible plans, you don't want to give people large copays, but if it's undervalued relative to the other services, then they become a money loser internally and becomes undervalued. And so I just think that these are really tricky in the context of cross subsidization and how pricing works in healthcare. But yeah, I just wanted to call attention to it. So I appreciate you taking the time on that topic here.
I'll just add one more comment.
Okay, good. Yes.
And this would be a great discussion to continue. I do worry that reference-based pricing potentially leads to more of this, because reference-based pricing starts to eliminate some of the opportunity to cost shift to lower cost services. And so if you set reference-based pricing, I'm just saying across the board at $250 of Medicare, many things will lose money. And the only way to make money on the things that are left is to reduce the ones that you're still losing money on, right? So you have what's left makes money at $250. I do have concerns about that. As Vermont is moving, and we talked about this conversation on Monday, you know, Vermont's appears to be moving somewhat away from value-based care and more towards price control. That could have some of the consequences you are worried about. But believe me, UVM Health, we think about it all the time, and we're going to do everything in our power to maintain as many services as we possibly can within the revenue that we're going to be bringing in.
And maybe this isn't the best forum to continue this conversation, but I just want to put one more concept into there. Is that it's interesting because I look at reference-based pricing as sort of doing the opposite, is taking this massive price distortion and overvaluation of things that say like CT MRI, that in Vermont were really high outliers, and bringing to have a more rational value as compared to the other things that are in the system, like primary care and obstetrics. So I think, anyways, this seems like a conversation that should continue, not in a budget hearing. So
yes, I agree.
All right. I have a few medical group related questions. On Monday, there was discussion about physician billing at UVM rates at affiliate hospitals, and there was some indication that this is largely legacy in areas like radiology and pathology. But are there any other specialties that bill as if they're UVM providers at affiliate hospitals? Anesthesia, general surgery. And then I guess the sort of within that question is, what if a ortho from UVM does a case at Porter? Does that bill at UVM rates or Porter rates?
I'm lucky I know the answer to this. Oh, go ahead, Ramsey.
I was going to say, I think Jen Gagnon's probably the best person to take that because there's a couple of questions in there that I think she could hit.
I'm happy to. Good morning. Thanks for the question, Member Merman. So we did a little bit of digging after Monday's conversation just to make sure we had the list of services. So I'll just sort of run through them for you. So we currently bill through UVM Medical Center for the professional only activities that take place in radiology, anesthesiology, that includes interventional pain procedures, pathology, and radiation oncology. So those are the hospital-based services where those legacy arrangements are in place that you mentioned. In response to your second question, if we have UVMMC-based surgeons who operate at CVMC or at Porter, those billings occur through those hospitals, throughout either CVMC or Porter.
Okay, and then I don't know if this goes through the medical group. I don't think it would, but what about other professional services like PT, OT, respiratory therapy?
I can't, so you're right, those don't go through the medical group. So Rick, Judy, anything that you can add to that specific question?
Yeah, pretty sure those go through the hospitals where those services occur, Member Merman, but we'll validate that for you.
Thank you.
Right, it is based upon location, and that's the one that generates the bill.
Okay. Another medical group related thing, the Alvarez A&M report discussed the non-clinical FTE at UVM Health Network and Health System and UVM Medical Center as being pretty high compared to comparators. I think especially in the administrative non-clinical FTE had 13%, with the comparison group being 5 to 10%. I was just trying to understand if there's been some investigation into this and what the justification for this is, or any efforts to try to bring this in with the comparator groups.
Yeah, so first of all, we dug into the numbers themselves. The 13% was higher than our actuals just because the way we accounted for GME related support specifically, but we're still higher than median. We initially set a target to reduce to get to around the 75th percentile, but then we saw there was actually an opportunity to decrease even further administrative FTE. Jen, you probably have the number in front of you for what we reduced in total, but there was a significant reduction in administrative FTE inside the medical group for physicians from 26 going into 27. Jen, can you validate that?
Yes, it was a material increase. So we're down to approximately 7.5%. I don't have the precise percentage right in front of me, but it was approximately 7.5%. Is the administrative effort in the FY27 budget. And we do think there's continued opportunity as we look at expense savings opportunities over time.
Do you know what the dollar amount is in that reduction?
I can look and provide that detail.
Okay. I didn't put it into a slide, but I can describe it. It's in the expense worksheet within adaptive. There's a section for medical group administration, which breaks into 3 rows: total salaries and benefits, non-MDs, total salaries and benefits, MD, and total other operating expenses. In 26 projected, that adds up to about $80 million. In 27 budget, that adds up to about $109 million, 38 and a half or so million more. Can you help me understand why the medical group administration is growing by such a large percentage, $38 million between 26 projected and 27 budget, especially in this total all other operating expenses associated with the medical group administration?
I'm trying to pull up the file that you're referencing, Member Merman, as you're talking. I'm gonna make sure I'm looking at the right categories. Apologies, this may just take me a moment. If you have another question while I'm pulling up the file, then we can come back to this if just in the interest of time.
All right. So we had a conversation on Monday about the hour changes from 32 to 36 hours. I think we talked about it today and Monday. I think Member Holmes brought up, is there going to be are you budgeting an increase? Our view for this expense, there's Dr. Leffler mentioned earlier that, we don't know what it's going to be, so how can we budget? But I mean, that's a 12.5% increase in the available hours of clinicians. I guess it's just hard for me to understand why you wouldn't budget an RVU increase or expense reduction if providers reduced FTE. So can you predict an estimate of how that will shake out?
Yeah, let me take a first pass at that one. So the increase from 32 to 36 is for our ambulatory specialty services. So everything that doesn't fall into ambulatory specialty, this doesn't impact. The second piece, and really this got more complicated than I actually thought. Most of these services aren't purely ambulatory, right? So they're covering call, they do inpatient consults, they do ED consults. And so a lot of the work is if you got an obstetrician, right, that may have OR responsibilities or L&D responsibilities across the entire piece, we want to increase their ambulatory clinical hours relative to that clinical FTE. So there's work in trying to figure out exactly what the increase is. Where I'm really trying to go to is a 12.5% across the whole medical group. It's just the ambulatory section, and then 4 of those providers that have mixed responsibilities, it's a little smaller than that. The other variable is we just went through the exercise of showing people what their schedule looks like when we increase it to 36 hours. And some of our providers are choosing to decrease their FTE to maintain their clinical hours. Obviously, that reduces the cost of that effort. It doesn't actually help us with access, and it's not going to translate to professional revenue increase. Another really big variable is for those folks in ambulatory specialty care that have procedural components of their job. It's TBD if we get to more patients in clinic, but we can't actually get them into the procedural spaces, that'll have a huge impact on what actually happens. And so I said on Monday, I personally, I think that we're going to, in some areas in our budget, probably beat our numbers, but that's if everybody keeps their FTE and our retention and recruitment goes as I hope it does. So one last comment, and I'll kick it back to anybody who wants to augment. we also, at the time of the budget itself, as I mentioned on Monday, we hadn't actually done a lot of that work yet. We weren't to it when we set the budget, and that's part of the reason I think that I mentioned dermatology specifically on Monday, where we can see where we've implemented these changes successfully in a pure, more clean ambulatory area. We can see that. We can see the impact, but early TBD. Was there anything in there that wasn't clear?
I mean, it's clear that it's not clear. So I think
Yeah,
that's,
okay. All right,
I mean,
fair.
that's, I mean, I think that's
Yeah.
where we are.
I'm trying to provide as much clarity as I can. And I think probably three months from now, I'm going to have the ability to answer this in a much more specific way.
Ms. Gagnon, did you have were you able to pull up that document at all?
We are in the process of doing that, although in my review just to search for that file, there's one note I'll make, and that is a difference in a shift in how we budgeted for our vacancy savings between FY26 and FY27. So we assume annually a certain number of our positions will turn over year over year, and we budget that as a vacancy savings factor. In the medical group in FY26, we budgeted that vacancy savings, which would apply to all of our clinical areas, in an administrative cost center. That became difficult for our operators to manage to that number because it was budgeted centrally. And so in FY27, we budgeted that vacancy savings factor in each of the individual clinical cost centers and not in the admin cost center. So that's a big piece of the variance, but we will do a bit of a deeper dive just to make sure you get a more comprehensive follow-up response.
Yeah, I think it's fine to have it in a written follow-up. Okay, on inpatient operations, I saw a little different information in what I read of 2022. I saw average length of stay of 6.8 days, and now a budgeted 5.8. I think, Steve, you mentioned 6.4 with a budgeted 5.67, but either way, a pretty significant improvement in length of stay. A few years ago, there was a analysis done that I thought it was actually a fairly sophisticated analysis done that you all did, looking at expected length of stay with a match group from some Vizient data that I think showed approximately, I'm going off my memory, a $60 million of associated expense by having a length of stay that was a day longer than the expected length of stay. Has that $60 million reduction been realized by this reduction in length of stay that you have been able to achieve since then?
Judy?
I will say that the estimate of how much savings over a year certainly is worth researching on where we are today. I will also say that right now it's a bit blurred because of inflation over time. So we'd really have to strip out the moment in time in which that was run, pull out the inflation. So I don't have an answer that yes, it's been realized, or no, it's not. I would have to look at the data closer and see if we can extract that. What I will say is that we look every single month at our cost of inpatient care and where it's rising and why it's rising. And what I have been able to see is it's in the more complex care delivered and not in the length of stay. Where we're seeing kind of the positive impact in the length of stay reductions is with being able to take care of as many, if not more, patients than when we were staffing for 450 beds. So in the FY27, we are counting on savings with that length of stay by adjusting our staffing to our patient demand with that lower average daily census that we're budgeting for FY27 at 390. So we are certainly optimistic that we will see the savings flow through as we've adjusted both meters on that, the length of stay and the average daily census, because adjusting one but having your average daily census staffed at a higher level will dilute some of the cost savings. So what we're doing in 27 is bringing both of those down in order to achieve those savings.
Okay. See, so it's okay. So in some of the budget worksheets, it says 470 beds for staffing, but you're staffing at 390 this year for the inpatient medical beds. Is that, or the inpatient? What's the 390 reference?
That's an average daily census. There will be days that the census is higher and we're staffed higher, and there will be days that the census is lower. So that is just the average daily census. In my narrative and in the presentation, one thing that I spoke of was back in like FY24 when we had so many non-acute or post-acute patients that did not have good placement opportunities. We were staffing at a higher number of beds needing to be serviced and cared for. And with the improvements that we've made in both length of stay and placement, working with our community providers, we're seeing the improvement in the length of stay. We're also seeing improvement in being able to, we're forecasting the improvement in being able to bring down some of our labor costs as well. Now, what we are seeing, though, on the opposite side are the costs of delivering some of the care to the patients that are of higher need, and that we're keeping a close eye on as we're looking at acuity. So that will always come into play, but where we are trying to level the playing field is based upon, let's say, a diagnosis. What's a diagnosis costing now, and what are we forecasting that to be? So more work to be done, more data to be reviewed, and more, we're working on actually achieving more insight through data as we're looking at our patient population and try to improve the cost of providing that care.
Yeah, we had the data discussion on Monday, but I applaud the efforts to have data-driven operations. I think it's really important. I think this analysis that was done a couple of years ago, it had all patients that were admitted with a pretty sophisticated peer group matching. I'm not saying this is the perfect analysis to do, but looking at national data on length of stay, it has decreased during this duration as UVM's length of stay has decreased. So I think a lingering question that I have, and I don't know if that, I mean, it's my question for me, you guys run your operations, but do you have some more, if you were to repeat the study now, are you still a day longer than national averages? Because national averages look like they've come down. And is there opportunity to, like things like extending cath lab hours, which you've done, to continue to reduce length of stay? And just to sort of point out, we've had this discussion in prior years that extending those cath lab hours doesn't just reduce length of stay at UVM, it reduces length of stay at all the hospitals that are feeding to UVM, many of which are out of network. And so it improves quality of care, timeliness of care. So I just a comment more than a question.
So,
all right, go ahead.
Remember, we do track O to E for length of stay on a monthly basis using Vizient data. So at all times, we know where we fall the benchmark. I don't have it in my head right now, but we can send you the most current stuff. I believe we are getting closer to benchmark in terms of O to E, but we'll have to send you that.
That'd be great.
And what I'll say with that, because it's also data that I review and it's shared all over the hospital, is that these are great improvements, but we're not done. We know we have some outliers. We know we have areas of opportunity. So this great work of reducing length of stay and being able to adjust our average daily census while caring for the same or more patients is, we've done great work, but we are not finished. This will have to be continuous improvement. It will have to be information that we continue to share. So it's not any type of work we're working to sunset.
Great. In the narrative, you notice a pretty sizable increase in the inpatient outpatient Medicare rate changes from 26, I believe, to 27. I think I saw 7.86 for inpatient and 4.3 for outpatient. those are some of the largest Medicare rate increases I've seen through the years of doing this, and compared to other hospitals' assumptions, what is driving those Medicare rate increases? Is there some special payment structure that's changed, or what?
We will provide the detail on how that is calculated, and we are going to have to do an adjustment based upon the final rule. But it is looking at our wage index. It looks at, the type of hospital that we are. And so there are multiple factors that go into that. It's not a special payment arrangement specifically for us. It's for the type of facility that we are. But happy to provide you with more of the detail around, especially when we run under the final rule, with what is driving our increase in our Medicare rates.
That would be helpful too, and it also doesn't match what is in the rate decompensation sheet. So to try to figure out how to see what, why they don't match and how to reconcile them would be helpful too. So I also looked at the payer revenue worksheet, which again, we don't have to, the details are not super important in this conversation, but when I added the Medicare and Medicare Advantage amounts together, because we seem to be having this large shift from Medicare Advantage back to Medicare because the loss of so many Medicare Advantage plans in Vermont, we would expect Medicare revenue to go up, Medicare Advantage revenue to go down. But I would think in aggregate, they're kind of should be relatively the same. There's a really substantial increase from 25 actuals. When I added the two of them together, I got about $443 million to $650 million in 27 budget. And from last year's projected to this year's budget is about a $93 million increase. What is it that's driving? Is this volume? Is this billing and coding, case mix index? How is this is a really substantial, $200 million increase over 2 years.
We'll provide you with the breakdown of that so we can make sure that you have the proper crosswalk in it. When I took a look at our percentages of inpatient, the percentages themselves were not moving materially, but the portion of inpatient that is being reimbursed under Medicare is certainly changing. So happy to provide you the detail for that, because we'll want to make sure that we crosswalk year to year as well.
And maybe I know the reason for this, but what I thought was really interesting in that is that the gross revenue is actually declining $330 million in that. So you have less gross revenue, more net revenue. And so to try to understand what that is, do you have any insight into that?
Well, the gross revenue charges, remember in FY26, our budget was built and we did not adjust our gross revenue. So the net revenue piece of it is going to carry kind of an anomaly on a higher gross budgeted charge. In 27, those charge reductions are actually in. So your reimbursement is on a smaller gross charge. So that is giving some noise to our reimbursement rates.
Okay, so I just want to clarify, just from my understanding. So the reduced charges you're talking about, what are the reduced charges that you're talking about?
Well, reduced several. Rick, I see that because we did this beyond UVMMC, if you want to lean in on that, as you came off mute.
Yeah, the biggest piece, remember, Merman, was tied to Act 55, so we had to drop our gross charges to essentially to match that decrease. So that's the biggest piece, and it wasn't again back to the short time frame that we had after our budget order last year. We just didn't have the time to adjust the gross revenue budget, but we did get the net revenue adjustments into the FY26 budget.
Were there other charges that have been reduced other than the Act 55 related charges? Like in large groups of charges?
Yeah, we reduced charges as well for the additional $100 million in the budget order last year. So some of the commercial comparisons that Steve went through on some of the services, we had to drop we had to drop charges there as well because we try to keep that in alignment. So if we're reducing our net revenue fee schedules and on the commercial plans, we try to match that up with what we're doing on the gross side.
Okay, so for instance, like the MRI charges, if the MRI reimbursements with Blue Cross went down, is that through a charge reduction or is that through a fee schedule reduction?
Both.
Okay. And the Act 55 charges, do you interpret that as the charges are 120% of ASP? Or the payment's 120% of ASP?
I'm pretty certain it's both there as well, but I don't know if there's anybody else that can validate that. If not, then we can get back to you on that, but I'm pretty sure it's both. No, the charge isn't 125% of ASP, but we did drop the charges by an equivalent amount of to match the drop in the commercial revenue.
Okay. All right, I think that's I have a few more things that I'm just going to submit in writing, like some of the budget to budget expense gross of implants and those sorts of things. But I think those I don't think we need to have a big discussion with today. So thank you.
Thank you. We're happy to take those questions and provide follow-up to you.
Great, thank you. And just for scheduling, I think we're supposed to go to 11:30 for UVM. We'll probably go a little bit over that, and we'll push back the other hearing. CVMC is supposed to start at 12:15, so we may need to push that back a little bit. I don't think there's going to be too much more. We certainly won't be going into the evening like we have in years past. Unless Member Holmes has a lot. Go ahead, Member Holmes.
I do not actually have a lot. So I'm not going to be the one pushing us into the evening. So, thank you for the presentation today and all the Q&A so far. I said it on Monday and I'll say it again. I mean it sincerely when I say I appreciate all the turnaround work that you all are doing and are going to continue to do to bring down expenses and the work you're doing to increase access and especially quality. I've noticed, more in this submission, the discussion about quality and the quality improvements that are underway, and the goal, Dr. Leffler, of having all your hospitals 5-star hospitals. I really appreciate that. And I just also will say, this budget submission, I don't have as many questions as I typically do going into this hearing, because this is a budget submission that I found to be very transparent and thorough and accountable. And I just had less questions about it. So between the discussion on Monday and today's presentation and the materials, I actually feel like I have what I need to assess the budget, although I'm, interested in my other colleagues' questions or Owen's questions that are coming up. But I'm actually going to pivot, and perhaps it's a little bit because I'm about to depart from the board, Dr. Leffler, and I think I'm going to use this small amount of time to ask you a much higher level question. We've tried payment reform. We've talked about it today a little bit, value-based payment and the movement away that you're observing. We've tried that to incent population health and control cost growth. Really hasn't worked in the ways that we had hoped. And we're currently facing, these Medicaid cuts that are coming. We've lost subsidies. We've got, demographic challenges. We've got high insurance premiums, all the things that we know. And these forces that you've all have talked about that are national forces increasing labor and pharmacy and supply costs, right? These are all things that we know are happening. We've talked about them all the time. You're leading this incredibly hard work at the health network and at UVMMC, in terms of reorg and downsizing and performance improvement and change management, which is really hard. And so my question to you is, with that recent experience in mind, and also your longstanding decades of experience as a physician administrator in Vermont, if you were solely responsible for hospital transformation, right? And the delivery system reform, moving away from payment reform, actually talking about delivery system reform and hospital transformation, No new resources. Forget the $195 million for a second. No new resources. And you were given the political green light, okay, to do what really needs to happen to improve health outcomes and lower costs for Vermonters, given all those headwinds that we have and a fixed amount of money that we have to spend on healthcare. Tell me honestly, and I've always appreciated your honesty and your integrity and your openness. I really want your honest assessment. What would you do in the next year and what would you do in the next 3 years? What do we need to do to actually transform the delivery system based on all of your learnings this year and in previous years? It's a tough question, I know, and a little bit off topic, but not really, right? It's related to all the work that we're doing in the next 2 weeks.
Thank you. I really appreciate the question and the opportunity to answer. First off, I actually think the 3-year perspective is actually more important. And here's why I say that, because you said the most important thing. There's not going to be more revenue. The revenue is going to keep coming down, which has to shift the focus to how can you do as much as possible with the same revenue or even maybe a little less revenue. And the intense pressure that UVM Health faces right now is that our revenue went down so quickly that you can only absorb these losses for so long. And the biggest fear, and I hope you're feeling it from me, is that we'll be forced to do things that we'll have to do them before we get our expenses where we need them to be. And so a 3-year horizon, a turnaround over 3 years, which gives you a little bit of breathing room to keep working on quality improvement, to keep working on partnerships across the state, to keep working on how can we do things differently across the state, how can we work differently with our insurer. It takes time. And so I would say that a little bit of breathing room, budget to budget, the budget is so short. We actually start building the 28 budget like in October, which kills me, but that's when we start thinking about what's going to go. So my first answer is some opportunity, understanding the revenue is going to be constrained. How can you do as much as possible with the revenue that's going to come in, not only for UVM Medical Center, UVM Health, but for all 14 hospitals? And I think some of the really important work that's going on in the medical group right now that Dr. Harrington's leading around fractional specialists across the state of Vermont, those kind of things take more than a year, but we'll have ongoing, you'll see people get care at cheaper cost settings that don't have to come to UVM Medical Center. I think what my optimism is that Vermont's a small place and we all know each other, and working together with our regulator, I committed to both Member Walsh and Member Merman that before we make hard decisions, we would come to you to talk about them and understand how to not do that. We can work with our legislators in ways that many other states can't. 14 hospitals is a small number. So I really believe to my core that a little longer window into how quickly we have to make the expense reductions will preserve a lot of care in Vermont, because I see that as a key part of the pressure that we face right now is how many months can you lose $15 million a month? How many years can you lose 40 million? Not very many. I'm not saying we have to have the losses be zero, but a smaller amount really makes a difference in how you stretch out the ongoing changes. What we're asking of our medical group right now is really, really difficult work. We're changing people's schedules. We're changing how they see patients. We're changing, but there's work going on behind it. And once again, Member Murren just brought it up. Improving Epic, our IT platform, improving the support we give our clinicians, improving how we manage inboxes will free up time for more patient care. Driving down length of stay, really what that does is it allows us to see more patients with less overall staff. If you can have your census be 390, but see the same number of people in a year, you've actually decreased the cost of care to the patients you're serving by managing that expense. So this is my answer to you, is that the hard work of expense reduction has to happen at every hospital in Vermont. I'm actually confident it is happening at every hospital in Vermont. It doesn't go as fast as the revenue coming out. And I understand that the shock of lots of revenue coming out maybe pushes you a little faster, and there's some value to that. So I really believe, I'm going to finish where I started this rambling answer, is a little longer horizon on this expense reduction, I believe gets us to a better solution for Vermonters.
But let me ask you this. You said 14 hospitals is a large number.
No, it's a small number.
It's a small number. I guess my question to you, is it, do we, as we're thinking about hospital transformation and we're thinking about centers of excellence and all of these things and expense reduction and ensuring appropriate volumes and ensuring that we can deliver care in a cost-effective way, how do we ensure that we're working holistically across the system? The hospital transformation that AHS is leading now is really looking at designing the delivery system in a way that actually meets the needs of all Vermonters with the resources that we have across the entire system versus individual hospitals trying to do expense management and preserve their own revenue. How do we move to that?
So I totally understand hospitals like Copley or Brattleboro making the most hard decision they ever have to make around birthing services. It's really driven by two things. Most importantly, it's driven by demographics. If there's enough babies being born in those hospitals, that really helps cover the overall cost of the service. When you drop below 250 babies per year or so, the just fixed cost of maintaining that service becomes extremely difficult. We could talk about quality also. So the work that has to happen is, okay, we expect we're going to deliver X number of babies in Vermont the next 1 to 3 to 5 years. Okay. Where are those babies? Where are the moms and dads living? How are we going to figure out what's a reasonable distance for them to travel to get care? I also think part of the answer is all of the prenatal care and postnatal care hopefully can happen close to home, even if you can't deliver babies at Copley or Brattleboro. Can we get 9? And then the only care that has to happen at another hospital is they have the baby, they quickly hopefully get discharged with a healthy baby, they go back home, and then postnatal services comes to them either through midwives or provider travel. I think there's a wide variety of things that we do in Vermont that we should understand the total number of that's going to happen, whether it's cardiac caths or delivering babies or primary care services, figure out what we think is reasonable distance for people to travel. In some instances, it might be a little more travel, but technology is making a lot of things easier to be close to home. More care can happen through telehealth. More care can happen through e-consults. And appropriately, some care, we will have our specialist travel to Newport or St. Johnsbury. We're actually working very hard with Brattleboro right now to make sure they can maintain oncology services. Their oncologist is retiring, and it's a fractional service as it stands now. It's almost impossible to recruit someone to be a part-time oncologist in a small community like that. I want to thank Dr. Harrington for having an open mind about how we could do that for them and make sure that care can stay in that community. It's critically important. That's our future. I think everything is partnering, is working together. I heard the nuance of a question from Member Walsh around, hey, would you come back if there's a service was losing money and ask for more revenue? We have to do our part with the constraints that we have, and I've preached that really hard to UVM Health this year, that we have to do our work first. But I do hope there are opportunities to work with our regulator and our legislator to preserve essential services, not only to be delivered by UVM Health, please hear that, to be delivered where it's appropriate, whether it's Rutland, Newport, St. Johnsbury, Copley. If they can do it cheaper and better than us and keep that care local, I'm all for it. I really am. So I think ultimately it's collaboration. It's working together with some little longer guidance than 1 year, which makes you do hard things to make a budget work.
I appreciate that, and given the time, and I'm going to turn it back over to Chair Foster. And since this is my last budget hearing with UVM, I just want to say I appreciate again all the hard work you're doing, and directionally, I really support where you're going and the hard work everybody's doing. So
I want to say thank you for all of your service to Vermont for 12 years. That's a long time to be on the Green Mountain Care Board, and we will miss you.
Thank you. Chair Foster, all yours.
I need a minute. I'm going to tear up. You will be sorely missed, Jess. On the comment about the multi-year guidance, that is something that the liaison team recommended, and it's something that we're evaluating and something that I support, just so you know. And with reference-based pricing, I think it'll be something that we end up doing. I think what we want to do is say, look, where's our endpoint that we're trying to get to from a Medicare cost basis? And what's the appropriate cadence with which we get there so that we do have the right runway to adjust those changes. So that is something the board is working towards actively on that. I just want to focus on the medical school since my colleagues asked great questions on the other parts of the budget. Kind of a high level question to start. Are there metrics and governance that is in place to track and review how the medical center's investments are performing at the medical school?
Rick, are you in the best position to take that?
I think I can speak to a very, very high level. I mean, some of the metrics that we look at in terms of the pipelines of providers that are being that are allowing us to hire new nurses, new docs, new APPs, any of the learners that we have in our facilities. Certainly, we track that over time because that's a key piece of the investment that we're making in the academic mission there. There is not anything that I see specifically, but I mean, we do track there is tracking that happens in terms of grants and clinical trials and the other things that our investments in overall help to support. Ramsey actually may, in terms of what you see and what happens at the College of Medicine, he may have a little bit more detail on how we're tracking the impacts of those investments at UVM.
So I'll add, and just hopefully add something. We have an affiliation agreement with UVM that gets negotiated over many years. It commits to what we're going to support, what UVM is going to support, and then we have a wide variety of leaders who have roles both at UVM, at the College of Medical School, and UVM. Dr. Harrington is the best example sitting here. He has appointments both through UVM Health and at the medical school, and we have ongoing regular meetings with UVM and UVM leadership, President Trump, and we do track how the affiliation agreement works and how we're getting what we need from our medical school in terms of pipelines, residents, et cetera. As we grow programs or recruit new chairs, there's a constant collaboration. We probably don't have exactly what you're asking for in terms of we got this many medical students, but it is part of the affiliation agreement. Is there more you can add, Ramsey?
I guess let me say that the greatest value that's out there is one that's really hard to track, and that is what the investment and the relationship is with the College of Medicine that allows us to attract, recruit, and retain our workforce. So it's not a great answer for a metric, except as it relates to recruitment and retention. And I will say that we're particularly seeing now the power of the concept of the relationship between our community affiliates with the medical center and recruitment into our community sites where they get to intersect with the College of Medicine. On Monday, I showed a slide of our recent success in both recruitment and retention. And I really believe that if you look at where we're being successful newly, it's in our community sites. And a big part of that draw is the college. So we track, obviously in my dual role, we obviously track how successful we are in our, research funding, et cetera, but that's not really answering the question that you're asking.
Yeah, and I suspect this might be an area where there's conversation opportunity to change our approach a little bit. And I appreciate that some of these things won't be amenable to tracking, right? Like you're not gonna be able to say, hey, we've improved recruitment and retention in correlation to our investment in the medical school. Like I doubt that will happen. There will be definitely other metrics that probably are. And I'm exploring this because I do think it could be an opportunity. So if there isn't an answer to this at this time, I appreciate that, and maybe it's something that we need to work on in the future. But are there benchmarks or targets that you're shooting for in relation to the investment in the med school? Like, for example, one of the things I think it's slide 3 in your opening presentation, you discussed the number of graduates and the 30% stay in Vermont. Are there metrics that you're trying to get to improve that number? Or are there other types of examples of, hey, here's our goal for this investment in the medical school?
I actually don't think we have measures exactly like that right now. I'd have to go back and read the affiliation agreement, which is long and, which, but, let us come back to you on that. I'd actually would like to work with you and understand some things we can work on together that would, help. Our medical school enrollment, I can tell you right now, is about as high as it can be because of fire marshal code for the room where we teach the first and second year students. That's really what's holding us back from bringing in more students and clinical placement sites. We already sent some of our students to Connecticut. But we're working hard right now with our nursing school to increase nursing enrollment. We're looking at more places to place residents across the system, which I think is a way that people will stay in other places besides Burlington. There is a lot of work going on in collaboration with growing our future workforce for Vermont and upstate New York. So I'd love to keep this conversation going and figure out measures that we could bring you that would be meaningful to the Green Mountain Care Board and to Vermonters.
Sure. Chair Foster, can I add too? I think that ultimately the metrics that we're following are downstream, and it's hard to really connect those things, right? So when we get to a place where the metrics for access are where they're supposed to be, it's sort of downstream of how well we recruit and retain. And we know we recruit and retain our own GME residents better than we do from outside the area. And we know that we keep our medical students as GME more successfully than we do any other group. And so if there's a way for us to find that, objective connection point along the way, it will take us from investment in medical school to the things that really matter, which is, getting access and stabilizing our workforce and getting rid of locums and travelers. And that's true for the medical school. It's also true for College of Nursing, Health and Sciences, and all of our other workforce pipelines.
Great, thank you. So by my rough calculation, about 36 graduates stay in Vermont from the medical school each year. It's about a $50 million-ish net investment from commercial money from the medical center to the medical school. Are there targets or goals to increase that number that stay in Vermont? And if so, what are they and how are you planning to achieve that?
I would say it's a philosophical goal. Yes, of course, we want people to stay in Vermont. We try to make sure that but I don't know that we have a number. But actually, that would be something I think would be a great metric we could bring back to you. Over time, are we getting more people to stay in Vermont? I think that is something we could show over time. And if we're not, try and understand how we do better. That actually occurred to me as you were asking the question.
And I'm the biggest Vermont homer you're going to find. So I think all 119 should be staying in Vermont. And I think we should really think about how we achieve that. Like, what can the medical, if you're giving out $50 million a year in investment, that's a huge investment. Having every one of those providers stay here and thinking about what we need to do that would be great. Relatedly, do you track what practices they go into? As we know that we have a dearth of primary care nurses, a whole suite. Are we tracking what disciplines they're in?
We 100% know what they go into and where they go. We know that. We have that data. I've showed it here at other meetings. We can bring that data to you.
And are there goals for particular growth in particular practices?
I mean, we are a primary care driven medical school. What students choose to go into is not when we admit the student and when they graduate, oftentimes they find something they love that changes over the 4 years. So, and I'll be honest with you, for some students, what they can afford to go into matters. If they have a huge amount of loans or debt, they may have a harder time choosing a low-paying specialty. And for some of that drives specialty care. There are scholarships. AHEC offers sums for primary care. We are committed to trying to train primary care providers, and every single medical student at UVM does a rotation in primary care to get them good exposure. I think there's more work to be done there, both locally and even more importantly, nationally, on the debt that some of our students face.
And yeah, I agree with that. And who is in charge of overseeing the investment from the medical center into the medical school?
Probably Dr. Harrington is probably our best connection between the two. He's the highest level leader who wears hats in both places. Would you agree, Ramsey?
I would say that the question that he just asked was who's responsible for the actual investment dollars? That's probably not me, but I am the connection point. Yes.
Yeah, I mean, overseeing it and driving the relationship, saying, hey, here's what we want to see out of this investment. Here's, what we're targeting. Here's what we're trying to improve on. The whole overall relationship.
Then Steve's answer is what you're looking for. Yes. Me.
I meet with the dean every 2 weeks or so, but the daily, weekly interaction is Dr. Harrington.
Great. And it looked like it's about $161 million total in support that flows through the medical school. 79 million approximately is government money, Medicaid, Medicare GME money. And then I think it's about $48 million net commercial was my rough estimate. And I think what the liaison team cited. What efforts are being done to maximize the government money and reduce the commercial money?
So it's IGT and some other things like that. Do you want to talk about that, Rick?
Yeah, anything that we're doing in terms of the direct GME reimbursement, we evaluate every year. So we have an outside consultant that's looking to make sure that Medicare revenue stream is maximized. We do have the Medicaid IGT that's supporting some of those costs. We actually a few years ago were hoping to implement a similar program for the GME IGT that we have with the state is on professional revenue, and a few years ago we started down the path of trying to create the same type of program for hospital-based revenue, and that window has closed, unfortunately, in this last year with the policy changes. But there still is an opportunity. So those intergovernment transfer agreements, instead of it being based on the commercial revenue compared to Medicaid revenue, now they're capped at it's essentially Medicaid revenue up to Medicare, but there still is a small opportunity there that we're pursuing with the state to further support those program costs.
And just from my perspective, I'm very concerned about the volume, the number of Vermonters that are commercially insured. And I'm sure you are too, because it is a real stress on your finances. And we are seeing a drop in the number of commercially insured Vermonters. $50 million moves the needle on insurance costs here in the state. To me, this is a regressive tax. It's not really based on income. It's based on what insurance plan you have, rather than a progressive tax. It's on a broader tax base. Have there been conversations or discussions on trying to change the structure of this so that it's not coming out of Vermont's small commercially insured pool of patients?
Trying to understand where it would come from if we didn't. I mean, I'd have to think about how we build our budget, right? So I think about where does revenue come in from? What are our expenses? How do we cover that expense? And we've already talked a lot. There's a lot of cost shifting built in there. If it didn't come from how it's built now, we'd have to try and figure out a different source for that revenue to cover that expense. We'd have to think about that, Chair Foster.
Yeah, I mean, what I'm really getting at is through the tax base. It's better, I think, for Vermont as a whole to have this come through a tax base as opposed to 300,000 commercial lives that are paying enormous amounts.
So I know that in many states, the medical school gets significant subsidy from the state government, and I think our medical school either gets $1 million, it might even have gone away. I'm not sure. It's the lowest in the country or close to the lowest in the country. So I'm not here to ask for Vermonters to pay more taxes, but I understand your question, and it's a fair one.
Well, I mean, effectively, Vermonters are paying a tax.
Yeah.
It's just 300,000 of them in a regressive way. So I don't find that to be great policy. And if there's an opportunity to evaluate that, maybe there's some benchmarking you all can do to look at the state support. I agree, the medical school is a tremendous asset for the state of Vermont, and it needs to be supported and it needs to be here. I'm just querying whether or not we have the right mix of government money versus, $50 million coming out of a small commercially insured market where we're seeing people drop insurance. That is bad for every hospital's finances. So it's a broader conversation that we can take up later, but I do think it's one worthy of having. All right, I think that's really all I had. I do want to have ongoing discussions in our collaborative process, non-regulatory process on how we ensure the medical school is delivering what we need in Vermont, that there's good governance over these investments, and that there are targets that we're maximizing these dollars. The medical center is really looking hard at every dollar it's spending, and we need to include within that umbrella the $50 million that's going from the medical center to the medical school. But that's all I had. One other, actually, different topic. Risk-based contracting. I, as one board member, definitely do support it. I want to ask you, Dr. Leffler, I know that you were in negotiations this last year and your team was with the insurers. What stumbling blocks are there? Because I know that you're going to need to increase utilization if you're going to make your numbers work with the price decreases, but that then creates the same problem of, financial hit to the insurers. Where are you on risk-based contracting and what are the hurdles, if you can be candid on that with us, please?
Yeah, so we have a very small risk-based contract with Blue Cross Blue Shield of Vermont for this year, but it was a good first step. We worked very hard on that. It's for our own attributed lives, our own primary care offices. I firmly believe that a larger risk contract, ultimately, I'd like to see one around our total commercial revenue cap, upside, downside based on that, because I think that would once again give us some of the stability that I'm thinking will really help Vermont hospitals. Having the data on both sides so that our commercial insurer, Blue Cross Blue Shield, can make a deal like that and understand the risks, how it's built into their premiums, understanding the upside downside for us. So in the current world we live in right now, we know that not always, but often if we exceed our total revenue, there is enforcement. This year, we're going to come in under our commercial revenue. There's no flip side of